Educational Use Notice. This training video provides general guidance based on current accurate practices. It does not replace clinical judgment, institutional policies, or official protocols. Users are responsible for verifying the content and implementing it safely within their professional scope of practice. No liability is assumed by the creators or affiliates of this video. AI-generated subtitle disclaimer. These subtitles are automatically generated and may contain errors or inaccuracies. Viewers should rely on the original audio in cases of uncertainty. Hi guys! Welcome to this video. It is the newborn unit orientation video. We have been working really hard with the maternity department to make this video for you students to help you in your maternity and NBU rotation. We're making this video to target three main problems. First, many times students will come into the rotation lacking a baseline or foundation of knowledge, and this impedes their ability to help with patient care. Secondly, throughout the rotation, the nurses do a lot of teaching, but without a solid foundation or baseline, the nurses end up doing a lot of repetitive teaching, which takes away from their ability to focus on patient care. And then finally, once the students get trained up and get that good solid foundation and are able to help with patient care, the rotation ends and the students leave and a new group of students come in and the whole cycle starts again.
So the goal with this video is to first give you as students a really great foundation of knowledge for you to feel confident walking into the NBU. Secondly, it's to reduce the amount of retraining that the nurses have to do that takes away from patient care. And most importantly, we hope that it will lead to better patient outcomes in the NBU. So the better foundation that you have as a student, the more that you can effectively contribute to patient care in the NBU.
So in this video, we're going to cover the newborn unit operations that include daily routines and workflow. We are going to cover touch time and general patient assessment. We are going to cover basic neonatal resuscitation as well as familiarization with the newborn unit equipment. We hope this video will be helpful for you as a student as you begin your clinical rotation.
So we'll see
you
soon.
So, welcome to the newborn unit. I'm Caroline Bonareri, and I'm taking the charge of the maternity unit as well as the newborn unit. So in this newborn unit, we usually have admissions from preterm babies who have been born from 24 weeks of life all the way to the 28th day of life. So any critical neonate that we have within that period is usually admitted in this unit. And we even have patients that are admitted here. Some are referred from the peripheral facilities that are around this area, and some are the neonates that complicate while within our facility. And I'm going to show you on the supplies that we usually use in the newborn unit. So this is the place where the supplies are kept. And here we have the medication that we need, and we have the daily use equipment and supplies that we usually use. And also in this unit, we have the emergency drugs, whereby they are placed in specific places whereby if you need an emergency drug and there's a case at hand that you are handling using the emergency drugs, you are able to access them and save the situation before you can always have additions from the main pharmacy. So we also have here we have supplies of the linen so that there is reduced infection from outside to the unit. And this is where the supplies for clothing and also the linen is kept. We also have drawers here where more supplies are kept. We have even the extra sheets that we need for the cardexing, for the continuation sheet that are kept here. When you're working in this unit, you are able to access those supplies. During an emergency, they are readily available. So in most cases, all the supplies that are needed in the newborn unit are stored in this cabinet. But there's always more supplies in the maternity unit. For example, there are supplies that are here have already been consumed, or there's another thing that is really needed in the patient care, and it's not within the supplies that are available here. We can always source more supplies from the maternity unit that happens to have to act as the major store that supplies to this minor store. So what you can do when maybe you need a supply that is not available here, you can send someone if you're two in here, or you can use the intercom to make a call, and you can always ask for the supply to be gotten from the maternity unit, and you're able to have it and use it for care. And now, in this newborn unit, it's critical that in case of an escalation of a case, you are in a position to call for help. And now we have this place whereby we have an intercom where if you need to call for help, if you need to ask for a supply that you need as an urgent care, this is the place whereby you are supposed to use this intercom to make a call. This intercom is connected to the whole facility, so it can be you are making a call to the lab requiring some samples to be taken. You need more supplies that are mainly from the maternity unit, which is a core unit to this, and you need to call a clinician to come and do a review. This intercom is connected to the office. Any supply that you need, any help that you need, and it's always advisable that you have to have two people in the newborn unit, because it's not always the case that you have someone on the other side to answer the call. So if you need help and you have used the intercom, the other side of the call is not answered, then you can send one of you who, as you are working to, one can go to the respective area and call for the help that you need. If it is a supply, then that person can always get to that place and pick the supply so that it can help in that case of an emergency. I'm going to take you through what is expected of you as a student as you come to your placement in the newborn unit. So you need to ask a question when you feel you're not understanding something, or you don't know why something is done or how it is done the right way. So you take the initiative and ask as many questions as possible. We also have a set of standards that is expected of you as a student as you work or as you help in the newborn unit. First of all, food stuff is not allowed in the newborn unit. Idling is not allowed in the newborn unit. You cannot just come and maybe having a sleepy day, or you are working in the night shift and you come to sleep in the newborn unit. So there is no sleeping in the newborn unit. There is no food stuff in the newborn unit. And the newborn unit being a critical unit, you have to keep the hygiene standard with the highest requirement that is set. And that calls for you working in collaboration with the nurse that you are on duty with the others that are ahead of you and are more experienced. So that is why the initiative of always asking a question before you do something, if you're not confident about as small as it is, it's always for the utmost patient care to always ask before you do. When you're not sure of something, you always ask. When you see something and it's the first time you are seeing it, always inquire, know more about it, so that as you participate in the care, you understand what you are dealing with. It is good that you know your patients. Well, the reason as to why it is important to know your patient, you are able to know what care you are giving. And by knowing your patient, I mean having a detailed history of the case at hand. You will not be handling all the patients, but that specific that you have been allocated for that day, it is your initiative to go deep, understand the condition that they have come with, the management that they are under, and in case of escalation, how it happens. And that scaling down helps you as a student to understand a case at a time, and also comprehend its management, so that in the subsequent areas where you have an encounter of that, you are able to build more expertise and more experience on it. And at the end of the day, you are able to offer the best patient care. As part of the standard care and part of the set rules that are set within the newborn unit, you expected that you should always be 2 students in the newborn unit. At no point is the newborn unit supposed to be unattended. So always be 2 students in the newborn unit. And at no point should you leave the newborn unit unattended. If one of you needs to maybe go and attend to some emergency, then another one has to remain behind to oversee the patients that are within the unit. In the newborn unit, it happens that the primary caregiver always happens to be the mother of the baby. And it is advisable and it's very critical that in whatever that you're doing as you are handling the patient, always involve the primary caregiver in your care. In the case whereby a situation escalates and you see a change in any patient that you're handling, always call the nurse that you are with in the unit so that you are able to inform them whether it is to a lower side, whether it is to a higher side. Always contact, always call for help and inform the nurse that you're with of any change in the status of the patient that you are dealing with so that appropriate escalation of care is able to be done.
Alrighty guys, so now we're going to go over the comprehensive newborn care protocols. It's a fantastic resource that was created by the Kenya Ministry of Health, and you're going to use it a lot in your NBU rotation and throughout maternity and throughout your entire career as nurses. So to access this, you can either find it on the desktop of the computer in the NBU. Just click the icon that's on the desktop and you can open it up, or you can just go to any Google browser or Microsoft Edge and open up a tab and type in Kenya Comprehensive Newborn Care Protocols. You hit enter and it should be one of the first links that pops up. I like this one that's from the University of Nairobi. So this is what you'll see when it opens up, this baby's face greeting you. And ultimately, this protocol book was designed to deliver high quality care, especially for really small and really sick newborns. It's intended to be used by pediatricians, doctors, clinical officers, nurses, other allied health professionals, and you and students. It's written in a very detailed but also understandable way with lots of diagrams and very thorough explanations, so it's going to be a great resource for you. So once you open it up, you can scroll through the first couple pages. It's a lot of acknowledgments, things like that. And then you'll eventually get down to the table of contents right here, right? So this is our table of contents. The way the book is organized is essentially into 3 chapters. You have chapter 1, which is newborn care clinical pathways. Chapter 2, which is your standard operating procedures. And then number 3, which is your common clinical procedures performed on newborns. Essentially what it is you have your chapter 1, like I said, newborn care clinical pathways, but that is the what to do section. That is the section that goes over resuscitation, managing seizures, things like that. It's the what to do. It's a lot of flow charts and it will walk you through what to do. So think chapter 1 is what to do. Chapter 2, your standard operating procedures, that is how to use the equipment. So when you think chapter 2, standard operating procedures, that's how to use the equipment, right? You see how to use the radiant warmer, how to use the suction, how to use the CPAP, things like that. So chapter 2 is your how to use the equipment section. Chapter 3 is going to be your common clinical procedures performed on newborns. So this is the how to do it, right? This is the how to do newborn resuscitation, how to administer oxygen. It's going to be how to insert an IV catheter, things like that. How to insert an NG and OG tube. Granted, that's a nursing level skill, but it's still great for you guys to be aware of, and you can provide assistance to the nurses and better understand what's happening. So this is a phenomenal resource. Again, just recapping, section 1, newborn care clinical pathways. That is the what to do. Section 2 is the standard operating procedures. That is the how to use the equipment. And then section 3, the common clinical procedures performed on newborns. That is the how to do it section, okay? So as for navigating through the book, there's a number of different ways you can do it. One, you can look at the table of contents and find the page number and go straight to it. So for example, if we are wanting to know what to do if a neonate needs newborn resuscitation, the what to do section is chapter 1. So we're going to look in chapter 1 right here, section 1, newborn resuscitation. Okay, we're going to see it's on page 15, so we can just scroll on down to page 15. And remember, you're always going to use the page numbers on the document, not the one in the viewer. So as you can see, there's a mismatch here, right? That page says page 11. This says page IX, Roman numeral IX. So we're always going to use the numbers on the document itself, not the one on the viewer. So for page 15, we're going to go till we see page 15 here. Okay, page 15 right here. So this is the what to do. It's a perfect flow chart that walks you through what to do for neonatal resuscitation, okay? Great resource. The other way to get to that is you can also just click the section itself, because all of these are hyperlinked. Okay, so I can just click on newborn resuscitation. It's going to just jump me right down there. So clicked on it. There we go, straight down to it. Okay, so either way, you can find the number, look for the page number on the document and scroll down, or you can just click the hyperlink in the table of contents. Okay. So that was for section 1. Now continuing on with resuscitation. And during resuscitation, you need to be using the radiant warmer, right? So let's say, okay, now how do I use the radiant warmer? So the how to use a specific piece of equipment section, that's section 2. Okay, so we're going to come down here. We're going to see using the radiant warmer. Okay, that's on page 45. We can scroll down till we see the page number 45, or we can just click it. So if we just click it, it's going to take us straight down to page 45 right here. And then it's going to walk us through how to use the radiant warmer. All of this is great information on how to use it. It's the pre-warming mode, it's the baby mode, it's the manual mode. It walks you through the different modes, how to use it, how to turn it on, how to prepare it for use. Great information, okay? Now, if we go back to the table of contents, continuing on with resuscitation, let's say we know what to do, right? We know what to do for resuscitation. We know how to use the equipment we're going to use. We know how to use the radiant warmer because we just went through section 2, right? And now we want to know, how do we do it, right? How do we actually do resuscitation? So that's what section 3 is. That's the how to do it section. So we're going to look here, newborn resuscitation. Again, you can scroll down to page 119, or you can just click on it, right? And I just clicked on it. So now we're in the newborn resuscitation, and it is going to walk you through exactly how to do it, literally step by step. Step 1, step 2, step 3, step 4, all the way through, okay? Again, I cannot emphasize enough how incredible this resource is, and I want you all to be so familiar with the in and out of this resource. On just an interesting side note, in the United States, I was in the United States Army National Guard. I was a medic there. I had the opportunity to go to a very elite training school within the U.S. military called Army Ranger School. It's a leadership school that teaches leadership through small unit and infantry tactics. And one of the things at the school that I found dictated if someone was successful or not was how well they could use our book. It was called the Ranger Handbook, and it had all the tactics we used and all their strategies and stuff inside of it, right? It was basically our protocol book. So one of the things that I really saw make people succeed or fail was their ability to use that resource. And it's no different for you guys, okay? Your ability to use this incredible resource is going to, a lot of times, help you succeed in dealing with really challenging cases and help you succeed to give the best possible care to your patients. So please download this on your phone. Make sure you are familiar with where it is on the NBU computer. Spend some time going through it, getting really familiar with it, and then actually use it when you're doing treatment. If you have to monitor a baby who is on oxygen, pull up the section on administering oxygen, as in that the how to do it section, okay? And go through that and make sure that everything is correct that's going on. I promise you, this is going to help you so much, and it's going to make you incredible nurses. Anyway, this is a great resource, and it's going to help you, and it's going to most importantly help these wonderful, beautiful babies right here, and it's going to help them grow and live full, long, successful lives, and that is the goal.
Hi everyone. In this video, I'm just going to be showing you how to do hand hygiene. So before coming on shift or whenever you start your shift, you should always do hand hygiene and ideally with soap and water whenever you come on shift. So for visibly soiled hands, visibly dirty hands, you always want to use soap and water, but for not visibly dirty hands, you can use the alcohol-based rub. So both are good practices for hand hygiene, but the best is with soap and water. So in total, washing your hands takes like 40 to 60 seconds. Very easy. I'm just going to show you how to do it whenever you come on shift. So you have your water, your soap here. Just turning on the water, getting your hands wet first. Okay, turn the water off. Grab some soap. Okay, and you want to make sure you get all areas of your hand. Make sure you get your thumbs, the back of your hands, palms, in between your fingers, and then you can also get underneath your fingernails. It's really important with neonates to make sure we're performing really good hand hygiene because they are at really high risk of sepsis. Hand hygiene is the most effective intervention for preventing sepsis, and sepsis is a very common diagnosis that we see here. So making sure to get all areas of your hands, back, front, in between, underneath your nails, your thumbs. Okay. All right, and then rinsing with water. Okay. And then either allowing your hands to air dry or wipe them with a towel, whatever you have on hand. You don't want to wipe your hands on your dirty pants. And then whenever you're using the hand sanitizer, same procedure, but you're not rinsing it off with any water or anything, and then just allow it to air dry, your hands to air dry. Okay, so we just went through how to perform hand hygiene, and you might be asking yourself, how frequently do I need to do that? So the World Health Organization recommends 5 moments for hand hygiene. The first is before you touch your patient. The second is before performing a procedure, such as a cannula insertion or before a diaper change. The third is after you're done with the procedure. Fourth is after you're done touching your patient. And then the fifth is after you're done touching the patient's surroundings, such as the resuscitator, the incubator, the baby's bed, or just bedside area. So those are the 5 recommendations from the World Health Organization on when to perform hand hygiene. So that's the basic procedure for performing hand hygiene. Again, very important for our little babies in the NBU. So I hope this video is helpful. I'll see you in another one.
So welcome to this video. In this video, I'm going to take you through a daily routine in the newborn unit. So first of all, before you get into the newborn unit, you need to do hand hygiene. And this happens to be the point, our first point in which we do our hand hygiene. So in this area, we do hand washing, and then you can now, once you're done with your hand washing, you can now get to the newborn unit. And the second step is you have to have an apron that is specifically designated for the newborn unit, and we usually have it placed here, and you take your apron and you have it on. So once you are done with the apron, now you have to go and see your patients. This is the main area where we have the admission done, and as you're coming to see your patient, this is where you are doing a confirmation on what you were told in the verbal report and now how it is translating to the actual patient that you are being handed over in the ward. Now you need to have the initial assessment whereby you do the vital signs and you do the general assessment of your patient to see how generally the patient is doing as you are being handed over, so that you know if there is an escalation that is needed, it is handled. If the vitals, there is a fluctuation, they are handled at that point. And once you're done with the initial assessment and you are comfortable that your patient can continue with the care that is at hand, then you now need to prepare for your day. We now come back to where we need to confirm if we have the required supplies, and this is the station whereby we need to have the supplies in place. So in this cabinet, you need to check on the emergency drugs, the fluids that you may need during your shift if they are available, the equipment that you use to do the monitoring of your patient if they are available, and if they are not available, you need to ensure that a restock is done by either ordering or having it from the main supply that is in the maternity unit. And that can be done through the intercom, whereby you call and you inform them of the supplies that you need, or one of you as a student can go to the maternity unit and get the supplies. So once all your supplies here are in check, you also need to have a check on the equipment that you're going to use for the day. So we're here. So in the equipment, you need to ensure that the Resuscitaire is in functional use and it's in ready to use mode. We have the concentrator here. You also need to ensure that it is in good working condition. The water bottles here are filled with fresh water and it's in a ready to use status. We have the bag mask that is used in resuscitation. You also need to ensure that it's in good working condition, clean and ready to use. We have the cylinder oxygen supply. So you need to have it on and tested to see if the supply can be readily available for use, so that you ensure that if it's not, it is set to a situation or to a case whereby it is in a ready to use status. We have the incubators that one is supposed to use. For example, if there's additional patients that are coming in, so you ensure that the incubators are also in good working condition, ready to use modes. We have the bins for waste segregation. In that morning shift is when you're supposed to check if they are full and need to be emptied, so that you take them to the respective area for segregation. We have the sharps box. You need to confirm if it is empty or it's full, and if it's full, it's supposed to be changed and taken to the respective area. And by so doing, checking all these equipment, and now you are in a position to be ready for the shift. And from there, then now you can go back to now having a general cleaning. This is actually done as you start your shift in the morning. So for high dusting, you need to go to the maternity unit whereby the main sluice room is, and you get the supply of the cleaning towels, the jig that you need to do the cleaning, and also the detergent that is used to do the cleaning. And as you come now, you do the high dusting, wiping the high surfaces, the areas with of the equipment that you're going to use, the incubators, the resuscitaire, the station where the supplies are placed, the cabinets, all those we classify them as high dusting surfaces, and those are done with the towels that you have readily available at the maternity unit, and the supplies of the detergent and the jig that is available in the maternity unit. We have designated mops and cleaning buckets that are specifically for cleaning the NBU floors. That is mainly to avoid the cross-contamination from maybe mops that have been used from other areas into the newborn unit. So those mops that are used in cleaning the floors of the newborn unit are specifically designated for newborn unit, and once you're done with them and you clean after, you have to return them to the specific area where they are stored for ready to use in the next shift. So in summary, daily routine in the newborn unit is step 1. Before you enter the newborn unit, you have to do hand hygiene in a station that is right in front of the newborn unit. As you enter, you need to have the baby-friendly apron on. Then you go ahead and see your patients that you have been handed on the verbal report, confirm if it is a true copy of what you have or there is any escalation by doing your initial assessment. Once you do the initial assessment that involves the basic vital signs and general assessment of the patient, and they are good, then you go ahead and check on the supplies and confirm that you have all the supplies that you need for the shift. You check on the equipment and you ensure that they are in good working condition, ready to use. Once you're done with that, then you embark on doing your general cleaning so that you can have a clean working surface area. And that involves using the specific cleaning buckets and mops that are designated for the newborn unit. And that is usually to prevent infection from the other wards to the newborn unit. Yeah, so once you're done with your cleaning, then you can now go ahead and now continue with your daily activities of patient care and even doing all the other activities that will involve your participation during the shift. I hope this video gives you an overview of the routine of what happens in the newborn unit and how you're going to implement that to ensure patient care is in the utmost. Thank you.
Hi everyone. In this video, we're going to be talking about touch times. If you're not familiar with this term, this is the standard of care for babies in the NBU. It's a scheduled time to perform patient care. So another way of saying that is you're just bundling all the care that you need to do for your baby at one time. It occurs every 3 hours during the day and night duty. So some example schedules of touch times are at 9, 12, 3, and 6, or 10, 1, 4, and 7. Touch times just happen every 3 hours throughout your whole shift. So whenever you're coming on shift, you start your touch time for your first baby, and then your baby ideally sleeps and rests and grows for the next 3 hours, and then you start your touch time again. So every baby has their own set of touch times. If you have a really critically ill baby in the NBU, your touch times might be more frequent, so every hour or every 2 hours. Touch times have a lot of great benefits. So one of them is that it reduces stress on the baby, supports their development, provides more thorough monitoring, which is really important for this hospital because there is not a continuous monitoring system in the NBU. It also increases efficiency throughout your shift, and it promotes family involvement. So touch times have a lot of parts to them. This list might look long and overwhelming, but as a student, it can be helpful to make a checklist of all the things you need to do so that whenever you're starting your touch time, you can check each of these off as you go. You can also see that some of the topics are covered in detail in other videos throughout the whole orientation video as a whole, but we'll touch on them briefly in this presentation. So touch times include vital signs, a head-to-toe assessment, feeding, diaper change, reposition, suctioning as needed, a pain assessment, medications if they're needed, blood work if necessary, and then interactions with the family.
So the first thing that you want to do whenever you're starting your touch time is grab a set of vital signs. This is a great baseline for how your patient is doing and how stable they are. So you're probably used to the vital signs that you learned for adults, but for babies, they're very different. They're done at least every 3 hours, but can be more frequent if your baby is really ill. So the first one is pulse rate or heart rate. The normal for babies is 120 to 160 beats per minute. Then SpO2, oxygen saturation, normally is generally between 90 and 100%. Temperature for babies, the normal is 36.5 to 37.5. And then respiratory rate is how many breaths they're taking every minute, and that is 30 to 60 breaths per minute is the normal. So the key thing for you to know as a student is whenever you're taking vital signs, if any of them are out of range or abnormal, you must notify the nurse on duty. So another part of touch times is the head-to-toe assessment, and this is just a brief list of all of the things that you would be looking for during your assessment. If it's helpful to pause on this slide and make some notes, feel free to do that. A really important part of touch times is the feeding. This is covered in detail in another video, but the key points for you to remember as students are that babies must be fed every 3 hours unless they're exclusively breastfeeding, and at that point they can feed whenever they want. Another key point to remember is that you should never orally feed a baby who is asleep. So by orally, I mean with the syringe, cup, or breastfeeding. So never feed a baby who is asleep. As students in the NBU, you'll be doing diaper changes pretty frequently. So this is also every 3 hours, either before or after the feeding, and you want to invite the mother to change the diaper. So whenever mom is coming in for the feeding time, you want to make sure that she brings all of the supplies that she needs so she doesn't have to walk back and forth between postnatal ward, C-section ward to the NBU. So for the diaper change, she'll need a new diaper, wipes, and possibly a fresh outfit and blanket. So as students, the key things that you want to look for is the diaper dry? So has the baby not urinated since the last time you changed the diaper? Is there any blood noted in the baby's stool? This can mean the baby might have an infection. This picture shows a little speck of blood in the stool, so it can be really small. And then, is there any skin breakdown? So if you notice any of these things, you want to notify the nurse on duty. Repositioning is very important during your touch time because it prevents pressure injuries. It promotes normal development, especially for the baby's head. It improves their breathing and circulation, enhances digestion, and supports their overall comfort. So there are a few different positions you can do. One is supine or laying on their back. Prone is laying on their stomach, left lying, and right lying. So every 3 hours, you want to reposition the baby. Suctioning, this is also covered in another video, but the main thing for you to know from this presentation is you should only suction if needed. You don't want to suction every drop of drool that you're seeing from the baby's mouth. You only want to suction if necessary. Pain assessment is very important because babies cannot tell you when they're hurting or they're uncomfortable. So some things that you want to look for is an increased heart rate, lower SpO2. The baby obviously might be crying, have a brow bulge, eyes squeeze, and their behavioral state is overall just inconsolable. So we do a lot of painful procedures to our babies in the NBU. One of them is a needle stick if you're getting a blood glucose. And something interesting is that the most effective intervention for needle stick pain for babies is breastfeeding. So if you know you're going to be getting a lot of blood glucose levels on your baby, you can invite the mom to come sit at the bedside, put the baby to breast, and then do your needle stick. Medications, so this is also covered in another video, but ideally they're given during the baby's touch time. So for example, given at noon, and that's just to avoid waking the baby in between their touch times, so whenever they're resting and sleeping and growing. However, if the medication needs to be given at a certain time, it should be given regardless of the touch time. Medication should be given by the nurse, and then anytime a medication is being given, you should always double check that you're giving the right medication, right dose, it's to the right patient, the right route. Do all your safety checks whenever you're giving any sort of medication. Blood work is ideally done during the touch time and only if necessary. A key point for you as students to remember is that obtaining blood for babies is very painful. So there are some things that you can do to help alleviate the pain for the baby. One of them is putting a glove on and allowing them to just suck on your finger, and then also swaddling them during the blood draw. And lastly, family interactions. As healthcare professionals, you never want to just start doing things to your patient without first explaining what you're doing and why it's important. So it's really important to involve the mom and family members in the baby's care because it builds a strong relationship, promotes trust between you and the family, and then it provides more patient-centered care. So there's a lot of things that mom can be involved in. The main one is KMC, or skin to skin. She can do the diaper change, give the baby a shower, touch the baby, swaddle the baby, and then help reposition her baby. You really want to empower the mother to take care of her baby. So again, these are all the points of a touch time, and I hope that this presentation was helpful, and I'll see you guys in another video.
Hi everyone. In this video, I'm going to be showing you how to get vital signs from your baby in the NBU, or if it's after a delivery. So to start, before you always touch patients, you want to do hand hygiene. So I have my hand sanitizer here and some gloves. So to start with the normal vital signs for babies, they're a bit different than adults. So for pulse rate or heart rate, the normal is 120 to 160 beats per minute. The SpO2 or oxygen saturation is generally 90 to 100%. The temperature is 36.5 to 37.5 degrees Celsius. And then the respiratory rate, or the amount of breaths the baby is taking every minute, is 30 to 60 breaths per minute. So those are the normal vital signs. As a student, you'll be taking vital signs at least every 3 hours for your babies. And if at any point your vital signs are out of range or abnormal, you need to contact the nurse on duty or the nurse in charge. So let's get started, and we'll start with the SpO2 and the pulse rate. So I have a monitor here, and you always want to make sure that your monitor has enough battery or is fully charged, because if you're not checking, these will die on you and you won't be getting the vital signs. So I have my monitor here, and I'll turn it on, place it here. For now, I'm just going to put it on the foot here. So you'll apply it here, make sure that it's not too tight and that it's not cutting off the baby's circulation to their foot. And then you'll give it some time to read. Whenever you're using the monitor, you always want to double check that it's accurate, because the monitors are not always right. So for example, if the monitor is saying the SpO2 is 95%, but the baby has blue lips, has cyanosis, then you need to notify the nurse on duty. So the monitors are not always right, and you should always double check them. So I've gotten the pulse rate and the SpO2 from the monitor. For the pulse rate, if it seems abnormal, you can always check manually. The pulse is here or here. Or if you have a stethoscope, you can listen for 1 minute and get the heart rate that way. But always double check with the monitors, because they're not always right. So the third vital sign I'm going to get is temperature. Again, the normal is 36.5 to 37.5. So you'll turn it on, and then we check under the armpit here
The most accurate spot to get a temperature is a rectal temperature, but that's not really done here. So you'll put it under the armpit until it beeps and reads. You'll look at it, see if it's in normal range. If not, you know what to do and contact the nurse on duty. So that's temperature. And then the last one is respiratory rate. So this is how many breaths the baby is taking every minute. You need to count for 1 full minute. You can use a watch, your phone, the clock on the wall, but you want to count for 1 minute because babies' respiratory rates can vary a lot. They'll breathe really fast and then they'll slow down a bit, go to sleep. So it's important to count for 1 full minute. So you'll look at their chest, look at their breathing, and you'll count for 1 minute. And again, normal is 30 to 60. So if it's out of that range, you'll contact the nurse on duty. So those are the main things that you need to know as a student for taking vital signs. Again, always double check the monitor because they're not always right. And if your temperature, respiratory rate, pulse rate, or SpO2 are out of range or abnormal, always contact the nurse on duty. Never be afraid to contact them and ask for help. So I'll see y'all in the next video.
Okay, welcome back again. I'm gonna go through the red flags that we usually have in newborn unit. Red flags means danger signs that you need to call for somebody or you need to call for help, somebody to come. So one is poor feeding. When you're poor feeding a baby that is not suckling well, is not breastfeeding, maybe is crying a lot, does not have time to breastfeed, you need to call for help. Lethargic, that is a baby that needs to somebody to come and assist you take care of the baby. We have apnea, seizures, that is conversions, fast and labored breaths, jaundice, that I'm going to talk about it, local infection, in temperatures that are high after exposing the baby is not they are not dropping the temperatures, vomiting, diarrhea, dehydration, discoloration of the abdomen, and then cyanosis of the lips and the tongues. That means the baby is not having enough oxygen saturations. So in our case here, if you're a student in NBU or somebody who is not a medic, you need help on those things that I've mentioned, you can call a nurse who will help you on how to escalate care on that baby who needs to be taken care immediately, because those are the danger signs that might kill the baby very fast. Thank you.
For this section of the video, we're going to talk about feedings. The goal is to promote safety and the positive growth of our patients. Babies should be fed every 3 hours. Babies should also not be fed for over 30 minutes. For them, feeding is like a workout, so it burns a lot of calories and uses up a lot of energy. As far as the volume your baby should be getting fed, follow the MO, CO, or nurse in charge's order. Another good reference to keep in your back pocket is the Kenya Comprehensive Newborn Care Protocols book. Breast milk is the best choice for your baby for feeding, but in the case that mom cannot produce enough breast milk, the other alternative is naan. The recipe for making naan is 30 milliliters to 1 scoop of naan. It's important to know if your baby is ready to feed, and usually the baby will let you know by crying and being very awake and alert. Even if the baby is not awake and alert, crying, and ready to orally feed, they still must be fed every 3 hours. If the baby is not ready to orally feed, you can proceed with an OG tube or NG tube feeding. You can use the OG tube and NG tube even if the baby is asleep, but the key thing to keep in mind is that you should never feed a baby who is sleeping orally, whether that be via cup, syringe, or breastfeeding. So now we'll actually get into the feeding part of the touch time, which is something that you'll do very frequently as a student. So I have Neonatalie here, and she has an OG tube in. The first thing that I've done is made sure that Natalie is stable. I've also made sure that the dressing on her face is secure so that the tube doesn't come out of her mouth when we're trying to feed her. And then the last thing I'm gonna do is make sure that the tube is in the right spot. So with my syringe and a stethoscope, you'll wanna pull up 1 milliliter of air, connect it to the port of the OG tube, and then you'll put your stethoscope over the baby's stomach and push the air in, and you should hear a whoosh sound in the stomach. And if you do, then the OG tube is in the right spot. So then I'll take this out. Natalie is stable and ready to eat. So I have mom's milk here, and I'm gonna drop 10 milliliters of her milk. Attach it to the end of the OG tube. And then let it flow. Something to keep in mind with these OG tubes is they're generally a size 8, which means it's a bigger tube, so the milk flows really fast. So whenever you're feeding, you want to go very slowly and only do 1 milliliter at a time, and then clamp the end of the tube once you've given 1 milliliter. And just go very slowly with the feed to make sure that the baby doesn't vomit. Okay, so we're continuing to feed until the milk is all done. And you're just going very slowly. Throughout the feeding, you're monitoring Natalie's stability. Now we'll talk about syringe feeding. Similar concept of you want to make sure Natalie is stable and awake and alert before you start. And I have mom's breast milk here, and I'm just using a 10 cc syringe. And then we'll start with the feeding. I have a blanket here just in case she starts to spit out milk or she vomits. And I'm just gonna slowly put in mom's milk, going very slowly again, 1 milliliter at a time. You're continuing to monitor Natalie's stability throughout the feeding. Something to keep in mind is that during a feeding, a baby might need to burp. So if they start not doing as well during their feeding, you can try to sit them up like this. Put your hand under their chin and then burp them. And sometimes that helps them with their feeding because they'll swallow a lot of air, and sometimes they just need to get that out. So after you've burped them, you can continue with the syringe feeding. And if you notice Natalie is in a side-lying position, instead of laying on her back, that's a safer position for feeding, so that if we're going too fast, the milk will kind of just pool in her cheek right here, and she can kind of pace herself. Okay. As students, you interact with the mother of the baby a lot. So it's really important that throughout her baby's stay in the NBU, that you continually educate her. One of the most important things to educate the mother on is that if her baby stops feeding or eating well at home, that is a true emergency and that she should bring her baby back to the hospital immediately for review by an MO. That concludes this video about feeding. I hope it was helpful, and I'll see you guys in the next video.
Good afternoon. Today we are going to talk about medical administration. And here we are going to emphasize about neonates. And remember, when I said about neonates, they are from 0 to 28 days. In administration of medicine to the neonates, there are a key thing that we should not forget. Number one, it's about weight. That's why we have weight monitoring of the neonate. Weight is used in calculation of dosage of drugs. That is very key. So we should have the weight of the neonate. The other thing, there are rights that we should follow while administering drugs. Number one, it's the right patient. And how should you know that it is the right patient? One, you confirm the name. The neonates are not talking, but confirm the name from the mother. We have the inpatient number that is written on the file. Confirm. We have other hospitals where the neonates are given the badge. So they are labeled in that badge. So you confirm. You know that whether it is the right patient. The other thing, it is the right drug. Ensure that the drug that it's prescribed there, it is the drug that you are giving. For example, if it is a penicillin, ensure it is a penicillin that it is given to that neonate. Number 3, it is the right dose. The right dose. Remember, we said that we calculated the dosage using the weight of the neonate. You should not overdose or you should not underdose. The other thing is the right route. That is point number 4. How do you know that it is the right route? The route is prescribed when prescribing a medication. If it is intravenous, if it is intramuscular, if it is subcutaneous, or if it is per oral drug. It is very important to follow that. The last but not least, it is the right time. The right time. How do we know that it is the right time? Time, in other words, it is frequency. In other words, it is frequency. We have a drug that is given once a day, a drug that is given twice a day, a drug that is given thrice a day, a drug that is given 4 times a day. That is the right time. Or in other words, you say it is the right frequency. Thank you. From here, we are going in the administration, practical now administration of the drug to a neonate. Welcome.
In this video, I'm going to be showing you the basics of how to draw up medication for your baby in the NBU. So to start, you always want to do hand hygiene first with some hand sanitizer, and then use gloves. And the supplies that you'll need other than gloves are some syringes, probably a needle, and then some water for injection. So for drawing up medications, you'll always need a flush to flush the cannula before and after you give the medication. So we have our water for injection here, and then for demonstration purposes, this is a actual medication. We'll say it's X-Pen. Okay, so I'll set that aside. But first I'm going to draw up the flush. So I have my water for injection. I'll just take the cap off the top, open my syringe. You'll need to draw up 2 milliliters, 1 milliliter before you give the medication, and then 1 milliliter for after. Okay. You might need to get some air out. Okay, so I have my 2 milliliter syringe. I'll put this back in the bag, making sure it's not getting dirty. And then I have my second syringe, which I'll use to draw up the medication. You might need to use a needle for drawing up the medication if it's in a vial. So you have the needle here, which I'll open, and you'll attach it to your syringe like this. Take the needle off. Okay. Then you'll take the cap off of your medication, open the vial, whatever you need to do, and then you'll draw up the medication. Okay, however much you need to give to the baby. And then you'll cap the needle again for safety. Okay, so you have your medication and your flush. Flush 1 milliliter before giving the medication. Then you'll give the med, and then you'll flush again with another milliliter, making sure that all of this stays nice and clean because ultimately it's going into the baby. So that's the basic of drawing up medication, and I'll see you in another video.
So when you are administering a drug to a neonate, first remember our rule. You confirm the 5 rights of drug administration. After confirming, do hand hygiene. Do hand hygiene. I will sanitize. I will sanitize myself. Then I will wear my gloves. For infection prevention. Then I have my drug. I have my flushing water to ensure that the line is patent. So point number 1, start by flushing the line. And before you flush, ensure our line it's very clean. It's not leaking anywhere. It's very clean. After you ensure it's very clean, take the flushing water, flush using 1 ml of water for injection. If it is patent, the baby is not crying or the neonate is not crying, no any other resistant, the cannula is okay. Go ahead, administer the medication. This is my medication. Then I will administer my medication. After I administer my medication, the last thing I will do, I will again flush my line to leave it clean as it was, using 1 ml of the water for flushing. After a flushing, if there is no any other resistance, the cannula is ready for the next medication. Thank you.
As Enoch said very correctly, you must verify the 5 rights before medication is administered. But additionally, there's something else to think about, and it is the speed or the rate at which medication is administered. There are different rates or speeds that medications should be administered. For example, epinephrine during neonatal resuscitation is fast. It is just a rapid push of the epinephrine, versus something like phenytoin that you would give in neonatal seizures. That is a very slow infusion, okay? Totally different. You cannot give something like phenytoin or another anti-seizure medication such as levetiracetam fast. You cannot give either phenytoin or levetiracetam quickly. This is because they are central nervous system depressants. So if you give them too fast, you can cause all sorts of complications, including apnea, respiratory depression, bad cardiac arrhythmias, severe hypotension, and even death. So it is absolutely critical that you know the rate or the speed at which you should give the medication. Again, I just want to reiterate, never ever rapidly administer phenytoin or levetiracetam. It can have horrible consequences for your patient. So if we look right here in the neonatal seizures guideline, just to show you guys an example of this, this is from the Kenya Comprehensive Newborn Care Protocols. So if we start out, your first line is phenobarbital or phenobarbital. It's IM, okay? That is an IM injection, right? That does not say IV according to the Kenya Comprehensive Newborn Care Protocols. I have seen phenobarbital administered IV before. However, if phenobarbital is going to be given IV, it must be a slow infusion with a maximum infusion rate of 1 milligram per kilogram per minute for neonatal seizures. If you do the math on this, it works out to be approximately a 20-minute or longer infusion. So it is definitely a slow infusion. At no point should you ever rapidly administer phenobarbital IV with a syringe or anything like that. That is wrong. Make sure if phenobarbital is administered IV, it is administered slowly. One way to accomplish this is to dilute the phenobarbital into a giving set and then run the giving set at a calculated drip rate to ensure the infusion does not exceed the maximum infusion rate for phenobarbital. Again, according to the Kenya Comprehensive Newborn Care Protocols, phenobarbital is indicated for neonatal seizures IM, but follow your local protocols and abide by the doctor's orders. If the decision is made to administer phenobarbital IV, make sure it is a slow infusion that does not exceed the maximum infusion rate of 1 milligram per kilogram per minute. After phenobarbital, the second line following the protocols, if you go down here, is levetiracetam, okay? And if you look, it says IV over 15 minutes. That is absolutely critical, okay? It's not, oh, I'm in a rush, I'm just gonna push it quickly. Absolutely not. That is wrong. Same thing if you look at the phenytoin right here, it is also over 15 minutes, okay? That's also absolutely critical. You must respect that and you must do that correctly. For all anti-seizure medications or anticonvulsants, you always should be on the lookout for respiratory depression. Even when administered properly, anticonvulsants can cause respiratory depression since they are central nervous system depressants. So anytime you are with a patient that received an anti-seizure medication, whether it is phenobarbital, levetiracetam, or phenytoin. Make sure you're watching the heart rate, the respiration rate, and the SpO2 very closely. And be ready to step in with an Ambu bag and supplemental oxygen if needed. And if respiratory depression or apnea or some other complication develops following the administration of an anticonvulsant drug, make sure you escalate care and get them the care they need immediately. So, whenever you are giving any medication, you need to know the 5 rights, and you also must know the rate or the speed at which you administer it, because if you do it wrong, you could really cause serious complications, including apnea, respiratory depression, cardiac arrhythmias, and even death. So, take this stuff seriously. Make sure you do it correctly. One last thing. As students, make sure that you are not administering medications to your patient alone, and that you are not initiating fluids for your patient alone. You should always have a nurse with you when you do these things, and that nurse needs to guide you and sign off on everything that you are doing before you do it. This is critical both for your learning and, most importantly, for patient safety. I hope that was helpful. I'll see you guys in the next one. Hey guys, we're going to talk about IV infusions. So whenever your patient is receiving an IV infusion, the nurse, CO, or doctor will give an infusion rate, and then there'll be a calculation that they do to determine the drops per minute. It's not your job to do the calculation, but it is your job to monitor the drops per minute. So once they tell you how many drops per minute, it is your job to monitor your patient and ensure that they are receiving the prescribed drops per minute. This is important because if the infusion rate is incorrect and you're giving something like D10 or an IV cocktail, then maybe their blood sugar was low, but if the drip rate is too fast, then that's going to make their blood sugar shoot up, and then the IV cocktail will be discontinued, and then over time their blood sugar will go back down, and it just becomes this big cycle of going up and down and up and down. And a lot of this can be avoided by ensuring that you have the proper drip rate going in your IV infusion. And the same thing goes for just administering regular normal saline or other fluids too. It's always important to have the proper prescribed drip rate. It's essential. Now, monitoring the drip and counting the drops per minute is very easy. What you're going to do is you're going to take a timer, and then you're going to start it and count how many drops you see within 60 seconds. If the drops per minute are too low, as in you counted too few drops per minute, you're going to increase the drip rate. If you counted too many drops in the minute, then you're going to decrease the drip rate. Then, once you make a change, you're going to reset your timer and you're going to restart it. And now you're going to count again for 60 seconds to see how many drips you have. You're going to continue with this count the drops per minute, make an adjustment, and then count again to confirm again and again until you get the desired drip rate. For example, if the desired drip rate given to you by the nurse in charge is 10 drops per minute, then you would continue this time and count, adjust, and then time and count to confirm cycle again and again until you get 10 drops per minute. Remember to reassess blood sugar as ordered and reassess the flow rate frequently, because this can change as the fluid in the Soloset changes and as the baby moves around and other things happen. So the fluid rate that you set can sometimes change, so you always want to reassess frequently to ensure you have the adequate, proper flow rate that will allow the proper infusion of fluid to your patient. All right, guys, that's it for this simple but extremely crucial skill. I hope it was helpful. I'll see you in the next one.
Hi everyone. In this video, we're going to be going over neonatal resuscitation and the most important things for you to know as a student. Starting off, what is resuscitation? So this is the process you go through to help a baby breathe or transition to life outside of mom's womb. It's done either at a delivery, a C-section, vaginal delivery, or it can be done in the NBU if a baby needs breathing assistance. This is from the Kenya Comprehensive Newborn Care Protocols. It's laid out very well, easy to understand, and it just goes through the steps of what you need to do after a baby is born. It's a really great resource for you as students. It's easily accessible online and very easy to understand. So starting off, the baby has been born. You've either attended a vaginal delivery, a C-section, and the baby comes out. So what's the first thing that you should do? So you need to ask yourself these 3 important questions. Is the baby term? So is the baby over 37 weeks? Does the baby have tone, or is the baby very hypotonic and floppy? And is the baby crying, or has the baby failed to take its first breath? So baby comes out, and you're thinking to yourself, is the baby term, tone, and crying? If you've answered yes to all 3 of the questions, you can start skin to skin, start some breastfeeding, delay cord clamping, and do newborn essential care. So this is what we want. But that doesn't always happen. So if you answer no to any of these questions, you should immediately cut the cord and transfer the baby to the resuscitator. So we've looked at the Kenya protocol for newborn resuscitation, and it's a great overview of what you need to do. So now we'll go through in more detail the components of a resuscitation. So the first thing is to dry and stimulate the baby. Drying the baby first helps stimulate them to take their first breath and start crying and breathing on their own. If you know it's a preterm delivery or if the baby is less than 32 weeks, you should prepare by getting a neonatal heat loss bag. It can also be food grade plastic wrap, and you just wrap the baby in that, not covering their face so that they can breathe, and it helps to prevent heat loss. And then just continue to gently stimulate the baby. This is usually done on mom's abdomen once the baby comes out. But if the baby is apneic, after trying to dry them off, continue to stimulate them. If the baby is still apneic or not breathing on their own, initiate positive pressure ventilation, that's PPV, and call for help immediately if someone is not already there to help you. At this point, it's an emergency and you need some help. So another important point of resuscitation is making sure that the baby stays warm throughout the whole process. A study that I read said that hypothermia after birth increases mortality by 2 to 3 times. So it's really important that our babies stay warm after they're born. So you should remove any wet blankets that you were using to dry them off and replace them with clean, dry linens. You can place a hat on the baby. Make sure the radiant warmer's at 100% heat or was set to pre-warm mode before the delivery occurred. And then if the baby is crying, stable, has peaked, you can start skin to skin with mom. Now moving on to delayed cord clamping versus emergency cutting. This is from the Kenya Comprehensive Newborn Care Protocols. And again, very easy to understand. If the baby has poor tone, is not crying and not breathing, that's when you need to immediately cut the cord and bring the baby to the resuscitator. But if the baby has good tone, is crying, and is breathing, you can delay cutting of the cord for 1 to 3 minutes. Now we'll talk about suctioning. So routine suctioning is not recommended. And what I mean by that is that you don't need to suction the baby just because you can. It should only be done if it's clinically indicated. So if there are visible secretions that are blocking the airway, if it seems like the baby is having a really hard time breathing, or if you're having difficulty establishing effective ventilation. So say the baby does need to be ventilated, you should not delay ventilating the baby to suction. If you know that this is a meconium baby, meconium delivery, suction is not recommended unless it's, again, indicated and there are visible secretions blocking the airway. Whenever you do suction, you want to avoid suctioning for more than 10 seconds at a time because you're blocking the baby's airway. So make sure that when you are suctioning, you give the baby a break in between. This is a similar suction machine to what you'll see in the NBU and in the delivery rooms. Something really important with the machine is that whenever you are suctioning the baby, there's a little thumb control valve up here. And when the valve is occluded, or if your thumb is on it, that's when the suction is on and going. But when your thumb is off the valve, the suction is not going. So whenever you're inserting the tube into the baby's throat to suction, you want to leave the valve not occluded. And then on your way out suctioning, that's when you'll occlude the valve. Now we'll talk about the golden minute. And this is just within 60 seconds, a baby should be spontaneously breathing or getting ventilation. So it's just a good thing to keep in mind that once the baby is born, after 1 minute has passed, this is a little check mark that you need to make. Has the baby started crying, is breathing on their own, or do I need to start ventilating this baby? So if after you've dried, stimulated the baby, you've done all the things trying to get the baby to peak, if they're still apneic, weak, gasping, or if the heart rate is less than 100, you should start ventilation. And if you have a monitor on hand, you should place that on the baby. So this is probably the most important slide. So if you're going to pay attention, focus in on this slide. And it's over positive pressure ventilation, or PPV. So this is the most important step in resuscitation. If the baby is not breathing after you've done all of your initial steps, you've dried, stimulated, maybe tried suctioning the baby, and the baby has not peaked, is apneic, you need to start ventilating the baby. So whenever you start ventilation, administer a breath every 3 counts to ventilate at a rate between 30 to 60 breaths per minute. So there's a certain rhythm, a little song you can sing to yourself whenever you're ventilating, and it goes breathe 2, 3, breathe 2, 3, breathe 2, 3. So that's 1 breath every 3 counts. Whenever you're ventilating, you want to assess for chest rise. If you have a stethoscope, auscultate for equal breath sounds and air entry into both lungs, and then also listen to the heart rate. Within 15 seconds, your heart rate should be increasing, but if it does not, then you would initiate steps of Mr. SOPA, which we'll go over next. So Mr. SOPA is not an official step of resuscitation, but it's a helpful tool for you to use if you're having trouble getting effective PPV. So M stands for mask readjustment. Maybe the mask has fallen off the bottom of the chin, or it's not covering the nose and mouth. You can try to readjust. R stands for reposition the head and neck. So maybe the baby's chin was on their chest and they need to be more in the sniffing position, or their neck is more extended. S stands for suctioning. You do the mouth and then the nose. O is open the airway, check for any obstruction. P is pressure increase for your oxygen. And then A is alternative airway. So at this hospital, they don't have intubation capability. So the next option is a laryngeal mask, which would be inserted by the anesthetist. If you need to initiate Mr. SOPA, you do not have to do it in this order. So next is chest compressions. So compressions should be started if after 60 seconds of effective PPV, meaning that you're getting chest rise, you're hearing equal air entry. So if you've gotten effective PPV, if the heart rate is still below 60 after 60 seconds of effective PPV, you should start chest compressions. So at this point, you would need 2 people, 1 for breathing and 1 for compressions. The rhythm is a little bit different once you start compressions, and it's 1 breath to 3 compressions. So 3-to-1 ratio. The rhythm goes 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. So the 1 and 2 and 3 is the compressions, and then the breathe is the ventilation. An important point with this is to make sure you're not compressing and pressing down on the chest whenever your partner is giving the baby a breath, because the air can't get into their lungs if you're pressing down on their chest. So you'll want to place your hands in line with the nipples, compress down 1/3 of the chest, and allow for the chest to fully recoil once you've done your compression. So if your heart rate is still below 60 beats per minute after 1 minute of effective ventilations and chest compressions, at that point you would consider administering adrenaline. So there are a few emergency medications that you can consider if you get to this point. The biggest one is adrenaline or epinephrine. This is indicated for persistent bradycardia despite effective ventilations and compressions. Another option is normal saline, which is indicated for hypovolemia. And then another really common option is dextrose 10%, which is indicated for hypoglycemia or a blood glucose less than 2.5. So we've gone through all of the different parts of a resuscitation, and this slide goes over the different roles that should be filled if your baby needs assistance breathing or transitioning to life outside of the womb. So the first role is a leader. This is ideally a CO or a MO and is the person directing the code, telling people what to do, assigning tasks, and making clinical decisions. So they might be the one who is telling the nurse to start drawing up some adrenaline. The second role is the chest compressor. This is the person who is doing chest compressions, and it's recommended to switch every 2 minutes to avoid fatigue and less effective compressions. The third role is the airway manager, and this person provides positive pressure ventilation and monitors ventilation quality. The fourth role is in charge of medications. So this person establishes a cannula, prepares medication, and announces when a medication has been given. The fifth role is a recorder or a timer. This person is recording events taking place and is calling out certain time intervals. So for example, it has been 1 minute since you started PPV, or it's been 1 minute since the baby was born. And the sixth role is a support person. So this person helps to control the crowd. Sometimes there's a lot of people coming into the room during a resuscitation, so it's good to get everybody who doesn't need to be there out of the room. They also help support the family, so maybe grabbing mom a chair to sit in the NBU so she can be aware of what's going on. And they're also a runner. So if there's a supply or piece of equipment that we need that's not in the NBU, this person would run to go get that. So in the case that you are in the NBU, or maybe you're alone at a delivery and you need help, it's really important that the way you communicate that you need help is very direct, clear, concise, and it states the urgency up front. So a really great example is I have an emergency, a critical baby in the NBU is gasping, and the oxygen saturation is at 70%. This baby is crashing and I need help right now. So do not accept I'll be there in a couple minutes or let me finish my lunch first. If your baby is crashing, it's an emergency and you need help immediately. You should not delay any life-saving intervention at any cost.
Hey guys, it's Andrew. I just wanted to jump in and expand on a couple things that Ellen was just talking about, because this is such an important topic, how to call for help. There are very few things that are worse than needing help and asking for help, but not conveying the need for help effectively so that help does not come in time, and ultimately the patient suffers as a result. This is an avoidable circumstance, and we want to do everything we can to avoid this at all costs. So, to avoid that, we're going to use a formula to ask for help, okay? So when you're asking for help, you're always going to include 3 things. Continuing on with Ellen's example from last slide, we said, I have an emergency, a critical baby in the NBU is gasping and the oxygen saturation is 70%. I need help right now. Okay, that's a great statement and has all 3 parts of what we're going to include. So let me break this down. So first and foremost, you are going to include the urgency of the situation. So number one is urgency, and we do that. We say, I have an emergency, right? The second thing you're going to include is the status of the patient, and we do that. We say, I have a critical baby in the NBU, okay? And then the third thing you're going to do is you're going to include when you need the help. So I need help right now. So those three things are the urgency of the situation, the status of the patient, and when you need the help. Okay? So those three things need to be included every time you ask for help so that there is no confusion about the situation. There's no confusion about what is happening, when you need the help, is it an emergency or not. This alleviates all of that confusion, okay? So urgency as number one, status of the patient is number two, when you need the help is number three. Putting that all together, it looks like I have an emergency. A critical baby in the NBU is gasping and the oxygen saturation is 70%. I need help right now, okay? That includes all the parts, it's concise, it's to the point, and it will get you the help you need. So, always include urgency, status of the patient, and when you need the help. Lastly, never be afraid to ask for help, okay? You never want to be in a situation where you regret not asking for help and you could have needed help, okay? Never, ever be afraid to ask for help. It is always a good idea. There's never a situation where when you ask for help, someone's going to get mad at you, okay? Never be afraid to ask for help because it is always a good idea. All right, back to Ellen.
So again, we've gone through all of the components of resuscitation, the roles, the importance of calling for help. So let's revisit the Kenya protocols on newborn resuscitation. So initial steps after your baby's born is to dry and stimulate as you assess for crying, breathing, and tone. Make sure they stay warm and continue to assess for breathing and tone. So it lays it out very easy to understand. If you answered yes to those, you can continue essential newborn care, but we'll go down the route that your baby needs resuscitation. So you answered no to my baby's not crying, not breathing, doesn't have any tone. So you should immediately cut the cord and transfer to a pre-warmed radiant warmer. You'll check the airway, clear if required, reposition the baby, check for breathing again. So we've checked for breathing, the baby is not breathing. So at this point you need to call for help and initiate ventilation at 40 to 60 breaths per minute for 60 seconds. So Kenya's protocols say 40 to 60, but the Newborn Resuscitation Program, or NRP, recently came out with a new edition that says 30 to 60 breaths per minute for ventilation is okay. So you would initiate ventilation. After 60 seconds, make sure that the heart rate is going up. Hopefully it is. Is the heart rate greater than 60 beats per minute? If not, then you would move on to chest compressions. Give 3 compressions for every 1 breath for 30 cycles in 1 minute. Use 100% oxygen, and then reassess. If the heart rate is still less than 60, at that point you would move on to giving emergency medications. So those are all the components of a resuscitation. You probably and hopefully won't have to do all of them at every delivery, but it's always good to be prepared for the worst case scenario. So I hope this video was helpful, and I'll see you guys in another video.
Good morning, my name is Peace, in the maternity ward working at Our Lady of Lourdes Mutomo Mission Hospital, and I'm here to show you how to prepare for delivery, whether it's a cesarean section or a normal delivery. First step that you need to have is a clean space. You have to have your resuscitaire working in pre-warm mode to prepare for the baby, because Most of the times when the babies are born, they're adapted to the environment in the uterus, and when they get out, they are at risk of hypothermia. So you should have your Resuscitaire working well and have all the equipment ready for the reception of the baby. So these are some of the things that you should have when preparing for the delivery. You should have your 2 warm blankets. You should have also all the equipment working well, like suction tubes. You should have all the thermometers. This is a cannula. We usually have a cord clamp, a tape measure for measurements, and the medications that are administered to the baby post-delivery, and a stethoscope.
To add on, for every delivery, you must have a functional Ambu bag, including a neonate-sized mask, O2 reservoir bag, and O2 tubing. Also, you need a functional heart rate and SpO2 monitor with charged batteries. Ensure the batteries are charged and functioning. Also, you need a set of neonatal nasal prongs in case the neonate needs supplemental oxygen following delivery. These items are absolutely critical for every delivery.
These are some of the things that you should get ready for delivery. We usually have, again, all the equipment like oxygen concentrators. We usually have suction machines, and you test whether they are working before the delivery. These are oxygen concentrator, and they're usually connected to the Ambu bag. So these are oxygen concentrator. You should test whether it's working well. Yes, we see that our oxygen concentrator is working well. This is our suction machine. You see whether it's working well. You connect it to the suction tubes. You connect to your suction tubes because some of the babies are born while they have aspirated meconium, and you also need your suction tubes for suctioning and make sure the airway is clear. So our suction machine is working perfectly. Post-delivery, you can have your students or else the delivery assistants that is helping you to do some things for the baby. We can have students taking measurements, that is head circumference, baby length, cord clamping, drying the baby, and giving medications post-delivery to the baby, and even giving the upgasco. Okay, we can have the medications that are administered post-delivery. We can have the chlorhexidine that is administered to the baby on the cord. It looks like this. So if you open, you drop it at the cord of the baby. We also have tetracycline ointment that is administered to the eyes to prevent ophthalmia neonatorum. And then we'll have your vitamin K and a dropper that can be administered. So you break the vial and there's a dropper. You pick from the vial and then to the baby. Guys, that is all about preparing for the delivery. See you in the next video. Thank you.
Hi everyone. In this video, I'm going to be showing you how to use an Ambu bag or BVM. These are very important because in the case that you do need one, it can save a baby's life. So they're typically used after a delivery if a baby has failed to take their first breath and initiate breathing on their own. And then it's also used in the NBU if a baby has stopped breathing. So it helps ventilate the baby and give them breaths. So we'll walk through the pieces of an Ambu bag. To start, you have the mask. This comes in different sizes. There's preemie, neonatal, and infant size masks. So you always want to make sure that it's the correct size. It covers their nose and their mouth, and it's not too big or small. You have the PEEP valve. So that's generally kept open to help control the amount of pressure that you're giving to the baby when you're ventilating them. You don't want to give them too much pressure because that can be bad too, can pop their lung. This area is where you actually give the breaths to the baby. You never want to completely deflate this part of the bag. It's just gentle with babies. And then you have the reservoir bag, which will inflate when you turn on the oxygen concentrator. You have the tubing, and then the oxygen concentrator itself. So before you come on shift or before you start your shift, and then also before delivery, you always want to make sure that your equipment is working and it's functional. So the way that you do that is you first turn on the oxygen concentrator, make sure that is plugged in and working. And then what you'll do is you'll place the mask on the palm of your hand, do a firm grip here, make sure that this reservoir bag is inflating, there's not any holes in the bag, and then you'll give practice breaths. You should feel some resistance on your hand here, and this is just to make sure that the bag is working. Okay, so our Ambu bag is working. We can now put it on the baby. Whenever you're putting it on the baby, we use a CE grip. So the C goes on the mask, and then the E helps lift their chin up. So the mask goes on the baby, the C is on the mask, and then the E helps lift the chin up, and then we can begin ventilating the baby. There's a rhythm that you do whenever you're providing ventilation, and it's breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. You want to look for the chest rise, equal air entry if you have a stethoscope to listen, and then you can also see if the heart rate is starting to increase. So again, this is the most important piece of equipment to know how to use as a student because it's life-saving, and you always want to make sure that this is working before a delivery or whenever you come on shift because you never know if you might need it. So I hope this video is helpful, and I'll see you in another one. I have a baby who was born in the first stage area in the bed, has not started crying, has no tone, and is not breathing. Let's start drying and stimulating. And Betty, if you can place a monitor on the baby. I've started my timer. Agnes, if you can check the airway for secretions. Okay, let's go ahead and suction. Baby still isn't really responding to stimulation. All right, let's go ahead and start PPV. Everlyn, can you place a cannula?
Breathe 2, 3, 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 breathe 2, 3. 2, 3, breathe 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 2, 3, 2, breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3.
Okay, it's been 1 minute since we started ventilating. I'm gonna do a pulse check.
2, 3.
Okay, the pulse rate is 55. Let's start compressions.
1 and 2 and 3, breathe 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 1 and 2, breathe 1 and 2 and 3, breathe 1 and 2, 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 breathe 1 and 2.
Okay, it's been 1 minute since we started the compressions. I'm gonna do a pulse check. You can continue ventilating. Okay, you can continue compressions. The heart rate is 50. Let's draw up and give 0.03 milligrams of adrenaline.
I've administered 0.03 of adrenaline.
Okay. Good job, guys. Keep going. Okay, it's been 1 minute. I'm going to do a pulse check again. Okay, the heart rate is 70, so let's stop compressions and continue ventilating.
Nice job, keep going. Nice job, keep going. Looks like the baby's regaining some tone. Keep going. All right, we've been ventilating for another minute. I'm going to do a pulse check. Looks like the baby's starting to cry a little bit. And the heart rate is 120, so we can stop ventilating. And the baby's starting to peak. Okay, so let's place this baby on a nasal cannula. We'll get a blood sugar, do the admission meds. We'll update mom, and then let's make sure to take really frequent vital signs of this baby.
Alrighty guys, that was the live resuscitation demonstration, and I hope it was helpful to see it and see how it should be done. It can feel in the moment chaotic, but remember to always stay calm and follow your neonatal resuscitation algorithm. Additionally, if you're in the moment and you're just standing there and you don't know what to do, always ask. Say something like, I don't have a job, what can I do? If you are just standing there, don't just stand there. Ask in what way you can help the patient. Ask, how can I help? And then go make yourself productive. Additionally, you always want to move with a sense of urgency, right? Like there is a life teetering in the balance, and we always want to make sure we're moving efficiently. Don't rush, don't go too fast, but make sure you are moving with a sense of urgency and being efficient. So one thing that is really, really important to remember is you can maneuver yourself, your BVM or your equipment, and even your patient when needed to make yourself more efficient. For example, if I have a BVM and I'm trying to ventilate the patient, I'm not gonna stay over here and ventilate the patient from over here. That doesn't make sense. So I can either move myself around to the head of the patient right here and use the BVM from this side, or I can even maneuver the patient safely, of course, safely maneuver the patient so that I can more efficiently and effectively do my job. So now I'm at the head of the patient and I can effectively ventilate. So going into ventilation technique, you always want to remember that you're using your CE grip. So the C goes around the mask, right? And your thumb and your index finger go around the sides of the mask and help make a good seal on the mask, right? And then your E portion of your grip is going to go under the patient's jaw to lift up their jaw into the mask. So you're taking the mask and you're using the C to make a good seal around the mask itself, and you're using that C, putting this onto the patient's face, but you are also using your E to lift the patient's face into the mask. Remember, you always want to help open the airway, and that also helps pull the face into the mask to get a good seal. So when you're ventilating, you've got your CE making a good seal, pulling the patient's face up into the mask. And when we breathe, we have good chest rise and fall, right? We're breathing at our rate, if we're just ventilating, of breathe 2, 3, breathe 2, 3, breathe 2, 3. Notice when I'm squeezing the bag, it is not a death grip on the bag. That is wrong, and that is going to cause harm to your patient. You can cause what's called barotrauma. You could even cause a pneumothorax. So you always want to gently squeeze the bag. It only really requires a couple fingers. It doesn't even require the whole hand to effectively squeeze this bag. I'm not squeezing too hard on the bag, so I'm not causing any trauma to the patient.
All right, so in the case that you have been giving effective ventilation to your baby and their heart rate is less than 60, you need to start chest compressions. So the way that you do that is by encircling your hands around the baby's chest, placing your thumbs in the lower third of the sternum,
And usually that's just below where the nipples are. So you place your thumbs there. And the rhythm for chest compressions is 1 and 2 and 3 and breathe. So in the case that you have to give compressions, you are always providing ventilation as well. It's never just compressions. So the rhythm is 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Make sure that the person doing chest compressions allows the chest to fully recoil after compressing to a depth of approximately 1/3 the thickness of the patient's chest. Additionally, about recoil, you always want to make sure you let your BVM recoil, as well as to let it refill with that supplemental oxygen that's in this reservoir bag right here.
1 and 2 and 3 and
breathe.
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 1 and 2 and 3 and
breathe. Alrighty guys, so when you start PPV, you do not stop until the heart rate is above 100 or the doctor tells you to stop. You do not stop doing PPV during a pulse check, so you continuously do your PPV. The only exception when you would very briefly just pause your PPV is if there are secretions or some sort of airway blockage that develops. You are going to briefly pause your PPV, suction the airway properly, and then make sure it is clear and resume your PPV. Remember, you never suction for more than 10 seconds in a neonate, and you're going to, after you clear the airway, resume your PPV. Then you will only stop once the heart rate rises above 100 or the doctor orders you to stop.
All right, and then for compressions, the only time you want to stop is for a pulse check, which should last no longer than 10 seconds. If the heart rate is above 60 beats per minute, or if a doctor tells you to stop. Lastly, I just want to mention for if you are in the NBU or if you're at a delivery and you need to do resuscitation for your baby, always ask for help. It is never a bad idea. It is never wrong to ask for help. And usually when you're doing a resuscitation, you need all the help you can get. So as a student, never be afraid to ask for help.
Okay guys, thanks for watching this video. We'll see you in the next one. Hey guys, welcome back to the video. We're going to be talking about equipment checks today, and I'm here with Paul.
Thank you. Welcome everyone. I'm Paul Mutomo, a registered nurse working here at NBU. Welcome.
So today we're going to talk about how to check your equipment when you first come on shift. Every day it's super important when you first come on shift, you always check your equipment to make sure that it's functional and it's working as you expect it. So if there's an emergency or a time you need to use it quickly, it is there and ready to go right when you need it. Alrighty guys, so now we're going to talk about the oxygen concentrator specifically. So this is an extremely critical piece of equipment that you're going to use in the NBU. Generally the way it functions is it takes the gas from the atmosphere, which is composed of carbon dioxide, nitrogen gas, oxygen, and a number of other different gases. And it concentrates just the oxygen up to a purity of 93% plus or minus 3%. That's what this is rated for. So it basically takes your regular 21% atmosphere and condenses that down to potentially 93% oxygen to give to your patient. So it's really, really important for patients who need respiratory support and are having trouble maintaining their own oxygen saturation. So to test the oxygen concentrator, you're gonna make sure that it is plugged in to the wall. You're gonna make sure that it is plugged in to the back of the machine. Make sure the outlet is on, and then you're gonna turn on the machine. We're gonna make sure that the humidifier bottle is filled with water so that we are providing humidified oxygen to the baby, and not just any water. It needs to be sterile water, or if you can't find sterile water, sometimes distilled water can be used. And the bottle itself needs to be cleaned. So I have filled these bottles and they are both clean. and they are between the minimum and the maximum water levels. So now I'm gonna make sure that the bottle itself is tightly connected to the lid. So I'm gonna tighten here. Yep, that's tight. I'm gonna tighten here. Yes, that is tight. Now I'm gonna make sure that the lids themselves are tightly connected to the oxygen concentrator machine. So I'm gonna tighten the lid itself right here. Make sure that's tight. Yes, it is. Make sure that's tight. Yes, it is. Okay, so I have filled my humidifier bottle canisters between the minimum and maximum water levels with sterile water. I have tightened the bottle itself to the lid, and I have tightened the lid to the machine. So this should be tightly connected to the machine on both sides. So now I'm gonna open up and make sure that I get oxygen flow out of the humidifier bottle ports, and also make sure that I see bubbling in the bottles themselves. So I'm gonna turn it up, make sure my ball raises all the way up to 5, because this machine is rated to put out 5 liters per minute. Some machines are rated to put out 10 liters per minute. Just make sure that you test that your specific machine is functioning correctly. So I've raised this all the way up to 5. I see from the center of the ball, it's at 5. You always measure from the center of the ball. I see bubbling coming out of the canister. I'm also gonna check to make sure that I feel air. There should be a little buildup of pressure. You can hear that. So I have oxygen flowing on the valve that I can see based on where the ball is raised to. I see bubbling through the canister, and I feel air coming out of the humidifier bottle outlet. So this one is functioning as I expect. Now I'm gonna test this side. Same thing, go all the way up to 5, make sure that the center of the ball reaches 5. You always measure from the center of the ball. I'm gonna confirm that there's bubbling here, and then I'm gonna confirm that I feel oxygen coming out. If I cover the outlet, I feel gas and I feel a little pressure. And now I know that my oxygen concentrator is functioning as I expect it to. If I run into any problems where I'm trying to test and I don't feel air coming out of here, or there's no pressure, or I'm not getting bubbling, I'm gonna confirm that my bottle is tightly sealed to the lid, and then the lid is tightly sealed to the machine. There's also some rubber seals that are supposed to be inside of here, so you can confirm that those are in place to make sure that you have a good seal. And if after tightening everything and making sure that your seals are in place and making sure that the machine is on and everything is how it's supposed to be, and the machine is still not working, immediately tell the nurse in charge so that you can get a functioning oxygen delivery device back to the NBU as soon as possible. So that's how you're gonna ensure that your oxygen concentrator is working. You should do this every single time you come into shift in the NBU. Thank you. Okay guys, welcome back. Now we're gonna talk about the oxygen cylinder. It's pretty straightforward, but it's also an essential piece of equipment. So I wanna make sure that we all have a good understanding of what it is, how it works, and what we need to do to keep it working. The oxygen tank itself is this large cylinder plus this bronze valve right here. So this is the tank body, and this is the valve. It's made of steel. It generally holds about 2,000 PSI, or pounds per square inch, of gas, specifically medical grade oxygen if you're dealing with medical oxygen tanks. So this is gonna hold a bunch of nearly pure oxygen. I believe it's like 99% oxygen. So this is more pure oxygen than your oxygen concentrator. So if you have a patient who is really, really oxygen dependent, the oxygen tank will be better for them because it provides a higher percentage of oxygen. So now I'm gonna tell you how to change the cylinder. You most likely will not be expected to do this yourself, but it is still very important you have the capability of doing it, because in the future you will be required to change these when you're providing oxygen to your patients. So first thing you're gonna do when you are changing the oxygen cylinder is, one, you're gonna do it before you run out. You never wait till you run truly out of this, because then your patient will be without oxygen. You always wanna have a backup plan. So when this starts getting down below 10% of its starting capacity, which is usually around 200 pounds per square inch, you want to start replacing this. So you're gonna first transition your patient from what they're this tank that they're using to another tank, another oxygen source, and then you can go ahead and discontinue this one and change it out. So to change it, the first thing we're gonna do is we're going to turn off the oxygen flow, right? So we'll say it was flowing at 5. We're gonna turn that off, right? So our regulator here is off. The next thing we're gonna do is we're going to use our oxygen tank key or oxygen tank wrench, and we're gonna turn off the main valve on the cylinder itself. An easy way to think of it is this is 2 pieces and each piece has its own valve. So you just turn off the valve on both pieces, right? You turn off the valve on the regulator and you turn off the valve on the tank itself. So now all the pressure is stored down in this tank, right? There's a little bit of residual pressure in this regulator. So the next step is we're gonna release the residual pressure, right? So we're gonna open this and just let it drain until it's out. So you can probably hear it whistling as it's coming out, but this is closed, right? So that was just the pressure that was left over in here, but this is closed, so no more pressure is coming up into here, no more air. So now the pressure is equalized. So in the regulator itself, there's no pressure other than just regular atmospheric pressure. So now we can go ahead and take off the regulator because this valve, the main tank valve, is controlling the pressure. So we're gonna use just a regular crescent wrench and we're gonna go ahead and unscrew this right here. Right, and you always wanna be make sure you're not standing in front of the glass, make sure you're away from it in case there is some sort of residual pressure we didn't expect and something pops or explodes. We always wanna make sure we're a little bit away from it so that we're not gonna be injured. So you unscrew the nut. And now I'm gonna get rid of this tank and get a new tank. All right guys, I got my new tank here. So now I'm gonna take this regulator, I'm gonna put it back on the new tank. So the way you're gonna take the new tank and put the regulator on it is basically the same process we just did in reverse. You're going to set the regulator into the main tank outlet. You're gonna tighten it. Just finger tighten it as best as you can until you cannot anymore. Okay, now you're gonna finish tightening with a wrench. Okay, so now it's tight on there. We're gonna make sure that we have our bottle cleaned and filled appropriately with water. So it's filled with water, it's cleaned. So now this has been tightened, or the regulator has been tightened onto the tank valve outlet. And we're gonna go ahead and open the tank valve. But we're gonna make sure that we look away from our pressure gauge because if there is a sudden increase of pressure and this glass breaks, we don't want our face, in front of the glass. So we're gonna stand off to the side and we're gonna slowly open the main tank valve. And we're gonna see the pressure start to increase on our main tank valve. See, we see it go up right there. Looks good. Okay, so now that is opened. Now I'm gonna test to confirm that this will open and my flow meter ball will raise. Right? Yes, it opens up. That's good. I have oxygen flowing and I can feel oxygen coming out of here. So now I've confirmed it's working. And now I can go ahead and initiate oxygen therapy with my patient using this tank. So one common question I get a lot is, why is it not all the way full? And a lot of times the tanks are only filled to about 2,000, maybe a little bit more than 2,000 PSI, and that's considered full, right? It's kind of like the speedometer in a car. It says it might go up to 180 kilometers an hour, but we all know that car is not gonna go 180 kilometers an hour, right? It's a similar thing. And just because the max gauge pressure is 3,500, it doesn't mean that's what the tank started at. So you don't have to turn it on and be like, oh my gosh, my tank is half empty. That's usually not true, okay? So just make sure when you get a full tank, you take note of where it starts That way you have a reference point to see how fast it is decreasing. As far as a couple important points about the regulator, so there's a valve ring, like a rubber seal that's supposed to be inside of this lid, okay? So if you go look up inside of here, I'll attach a picture, but if you look up inside of there, there's supposed to be a ring that basically seals the lid onto the canister. So you always wanna make sure that's in there, otherwise you'll get air leaking out of the sides. Additionally, many times there's supposed to be a rubber ring seal in this white portion as well that attaches the canister to the rest of the regulator. So there's supposed to usually be a rubber seal inside of here. I don't know if you can see in there, but there's a rubber seal. So you want to make sure that's in place as well. And then finally, when you are filling your canister with water, you always want your humidifier bottle to be clean, right? Because the air comes across this regulator, down through this blue straw, and then is bubbled out through this white tip right here into the water that then bubbles up. And now this humidified air comes up out of a hole that's on the inside of this lid, down this Christmas tree portion outlet that is then attached to some sort of tubing, right? So you always want to make sure that this bottle is clean, because anything that's in it gets in the water, and you always want to make sure the water is clean, because anything that is in the bottle or in the water is going to be in the air that then the patient breathes in. So if you have mold or dirt or something in there, that's literally going into the patient's lungs, and we don't want that to happen. So always make sure your humidifier bottle is clean and filled with clean, sterile water, or if you do not have sterile water and your medical director approves it, distilled water can be used. Another point with the humidifier bottle is that oftentimes if this is filled with too much water, it will actually bubble up and start coming out of this outlet. It'll go through the tube and potentially could go to the patient. So you always want to make sure you don't overfill this so it starts bubbling over and leaking into the tube that's going to the patient. To the same point, you also don't want it to be underfilled so that the bottle is not effectively humidifying the air. So always make sure that your bottle is filled up enough that it is effectively humidifying the air, but not so much that it is bubbling out and bubbling over and sending water out of this outlet through the tube to the patient. Alrighty guys, welcome back. Now we're gonna talk about the Pumani bubble CPAP machine. So generally speaking, let's talk about what CPAP is. So CPAP stands for continuous positive airway pressure. And what that means is you have a device that is providing a constant pressure of air into the patient. In this case, this is a nasal CPAP, so it's going to provide a constant pressure of air into the patient through nasal prongs. This is important because it can help the patient breathe in a number of different ways. In the upper airway, it helps prevent the tongue and some of the soft tissue from falling and obstructing the airway. And then in the lower airway, it can help to prevent the alveoli from collapsing, right? So if the alveoli don't have enough pressure in them, they can actually get shriveled up. Obviously, if they have too much pressure in them, they can rupture, so too much pressure is bad and too little pressure is bad. But CPAP specifically helps with too little pressure in the airways. So it helps to keep the alveoli open. But again, you always want to use your CPAP within the limits that is described in your protocol to make sure you don't give too much pressure to the patient and actually cause rupturing of the alveoli or potentially causing a pneumothorax. So you always want to make sure you follow the protocols. The comprehensive newborn care protocols from Kenya, released in 2022, are fantastic, and they're extremely detailed in going over how to use CPAP, everything from setting it up, testing the machine, getting the baby ready, and all the way to escalating the care, increasing the treatment, and then eventually decreasing the treatment and stopping the treatment once the baby gets better. So let's talk about our machine specifically right here. This is the Pumani bubble CPAP. And Essentially, it functions by taking air. It's a combination of room air that it gets from the back. There's a vent back here on the back of the machine that takes in room air. And then you also hook up supplemental oxygen, either from an oxygen concentrator, an oxygen tank, or from an outlet on the wall that has oxygen. Some hospitals have oxygen outlets on the wall, but here we use either an oxygen concentrator or an oxygen tank, and you hook the oxygen tank or concentrator up to the CPAP. So it is bringing in atmospheric air from the vents on the back, and then it is also having oxygen pumped into it through this O2 port, and it is blending those two sources of air together. And what that does is it allows you to give air to your patient that is a higher fractional percentage of oxygen, or FiO2. And you control the percentage of oxygen based off of how you mix them right here. And I'll get into that in just a second, right? But essentially we're taking nearly pure oxygen from the oxygen concentrator or oxygen tank mixed with atmospheric air from the vents on the back. It comes together and then it comes out of this port right here. And it goes through this tube, through the tube, up and out of this nose piece right here. These nasal prongs, maybe I'll hold them down here so you guys can see better. These nasal prongs. So it comes through this tube up to these nasal prongs. It can go into the patient right there. And then it's also a continuous tube into the expiratory tube. So that allows any air that doesn't go into the patient, or if the patient exhales, it also allows air to escape. So it's providing constant pressure to the patient, and then air can also keep going to the expiratory tubing, which goes from here back up through this bigger tube and over to this bottle right here. Now it's like, why is it in a water bottle? That's a good question. If you've ever had a glass of milk or a soda with a straw in it and you go to blow bubbles, like you blow bubbles into your milk or your beverage, right? It takes pressure to do that. And the deeper the straw is into the beverage, the more pressure it takes. So this water bottle is actually providing or maintaining the pressure in our system. I'm going to show you this right here. There's actually a straw in this bottle that you can see right here, right? So you have a straw in there, and then when we put it in, our water level, right? We can increase our water level or decrease our water level, and that changes how deep the straw is into this bottle, and that changes the pressure in our system, right? So it's actually called centimeters of water, and that is our pressure. So right now we're at 6, right? We're at 6 centimeters of H2O. So that is a measure of pressure. So if you want to provide more pressure, you can increase that. If you want to provide less pressure, you can remove some water, right? But this is ultimately what regulates the pressure in our continuous positive airway pressure system. Now, to blending the oxygen. I said we were going to come back to this, right? So we have some nearly pure oxygen coming from the oxygen concentrator, some atmospheric air coming from the atmosphere, right? So it gets mixed together based on how you set these two dials, right? So we have our O2 flow. So this is the flow coming from our oxygen source, and we have our total flow, right? So the overall equation is our atmospheric air in liters per minute plus our oxygen in liters per minute, right? Those two added together will then make up our total flow. So if our total flow is set at 6 and our O2 flow, as in coming from our oxygen concentrator, is set at 3, total flow of 6, oxygen makes up 3 of those liters. That means 3 liters of atmospheric air are being brought in. All right, guys, to show you an example, I have the oxygen concentrator turned on, and I also have our CPAP machine turned on, and I have my dials set here, okay? So I have it set on how the Kenya Comprehensive Newborn Care Protocols say to start the CPAP treatment, and that is with a total flow of 6 liters per minute, which is measured right here, and you always measure from the center of the ball. Not the bottom, not the top, you always measure from the center of the ball. Right? Then I have my O2 flow according to the Kenya Comprehensive Newborn Care Protocols set at 3 liters per minute, right? So I have 6 right here, I have 3 right here, and then the protocols also state to have 6 centimeters of water in here to maintain a pressure of 6 centimeters of H2O in our overall circuit. So as you can see, there's no bubbling going on right now, but if we were to attach this to a patient, or if we were to test it by pinching these nose piece prongs, then we will see bubbling in the bottle. So now we have bubbling in the bottle because it is a pressurized circuit. So that means there is 6 centimeters of H2O pressure in these tubes. Alrighty guys, a few quick reminders. I'm going to go through this relatively quickly, so feel free to pause this and read all the way through it if you would like. Increasing the oxygen flow rate is going to increase our percentage of oxygen, or our FiO2, and this can help patients with low SpO2. On the other hand, increasing the water level increases the positive end expiratory pressure, also known as the PEEP, and this can help patients with difficulty breathing, often seen in neonates as retractions or grunting. Again, make sure you follow your protocols, everything within normal limits, because again, too much pressure can be bad as well. So make sure you follow your protocols, but these are just 2 general trends that we see. Continuing on, CPAP only works on patients that are breathing on their own. Never use CPAP on apneic patients. Apneic patients need PPV with an Ambu bag. They do not need CPAP because CPAP will not work on apneic patients. Next, never troubleshoot problems with the CPAP while the baby is on CPAP. Obviously, if it's not working, don't leave the patient on a therapy that's not working while you try to fix it. Put the patient on another oxygen therapy, fix the problem with the CPAP, then resume CPAP treatment once the system is functioning properly again. Next, if the patient is doing well on CPAP treatment, then rapidly becomes worse, assess for the possibility of a pneumothorax. It is possible that there was a rupture within the lung that has caused air to accumulate in the chest cavity, preventing the lungs from inflating properly and decreasing the patient's ability to breathe. Also, keep in mind the possibility of a machine malfunction. If your patient spontaneously gets worse, always keep in mind that the machine can malfunction. So you want to check to make sure your machine is functioning properly. Check all the tubing, make sure that everything is connected, ensure that the machine is functioning as it should be. Also, ensure that your oxygen source is working. It is possible that your tank has become empty if you're using an oxygen tank. Hopefully not, because you are checking it frequently and replacing it before it gets empty. But if something happened and the tank became empty, that could be a source of the problem. Also, it is possible that the oxygen concentrator failed or stopped working, so make sure you check your oxygen source and continue to assess anything else that might be a problem to try to fix whatever's going on with the patient. Obviously, if the patient rapidly becomes worse, this is an emergency, especially if it is a pneumothorax. But regardless, if the patient rapidly becomes worse, make sure you get help. Call the doctor immediately, get help. This is an emergency. CPAP absolutely is a life-saving treatment, but we have to do it correctly. So it's important that we know how to use the machine and how to make sure that we administer the therapy properly. Okay, so now when you are in the NBU and you are monitoring a patient on CPAP, there's some important things that you want to look out for. First and foremost, the pressure of CPAP should never go above 8. So your bottle should never have more than 8 centimeters of water in it. Also, you want to make sure you are effectively positioning the cap with the clips and the nose piece on the baby. These tubes are very heavy, right? They're very heavy and they like to pull every which way, and it's hard to get it properly positioned on the patient, but it's very important because we want to, 1, make sure that it's comfortable on the patient, 2, not causing any harm, and 3, we want to make sure that none of the tubing is like kinked, or make sure the nose piece isn't twisted or something weird like that where it's making our treatment ineffective. So you always want to make sure you use the cap provided and these clips to effectively secure this to the baby, which again requires reassessment because the babies move and things like that. So you want to make sure that this is as comfortably and effectively secured to the patient as possible. These nose pieces right here, they should not be pressed all the way up into the nose, right? They should be thoroughly in the nose, but you don't actually put this horizontal tube all the way to the septum, there's actually a little bit of a gap, enough so that these are well into the nose, but you're not actually pushing this horizontal piece all the way up towards the septum, so you're causing any sort of damage. You wouldn't want to do that. You want to make sure there's a little bit of a gap. Again, as far as nasal care goes, the comprehensive care guidelines state that you should provide nasal saline drops to the patient in order to prevent skin breakdown. So there's a lot of stuff you need to do to monitor your patient and make sure that this treatment is going well and make sure that it's not causing any sort of skin damage or breakdown. As far as red flags to be on the lookout for when you are monitoring a patient on CPAP, you want to be on the lookout for secretions, because it's especially important with CPAP. If the baby is creating secretions, the CPAP, or the pressure we're pushing into the patient, can actually push those secretions down into the airway, and that can obviously worsen the patient and their ability to breathe. So we want to be on the lookout for secretions and make sure we suction appropriately and only as needed, but as needed in case there are secretions. Also, you always want to make sure you're not providing too much pressure, because that can cause a pneumothorax. So ensure you are following the comprehensive newborn care protocols on how much flow rate you should have, what your oxygen percentage should be, and what your overall pressure should be. Additionally, a patient on CPAP should have an OG tube in place, because another thing you need to look out for is gastric distension. Because we're pushing air into our patient, that can accumulate in the stomach, causing gastric distension. And if their stomach inflates, that can put pressure in the chest cavity, preventing the lungs from inflating as much. It can also cause vomiting. So we want to make sure we're not putting too much air into the tummy or the stomach of the patient, because that can cause other problems. So the patient on CPAP should always have an OG tube in place with a syringe attached to it with the plunger out, so that the OG tube can vent. Again, there's way more things that we want to be on the lookout for CPAP. I'm not going to go through them all right here, because you have the comprehensive newborn care protocol and you all can go through that. So please take the time, go through all the things to know about CPAP in the comprehensive newborn care protocols, all the things to look out for, the red flags. Look up the indications for CPAP, the contraindications for CPAP. Be sure to have the comprehensive newborn care protocols opened and follow them when you are using this machine. It is absolutely critical. This is a machine that can save lives, but you can also cause harm to your patient if you do this incorrectly. So be sure you follow the comprehensive newborn care protocols on how to use and administer and monitor CPAP. You guys are not going to be the ones prescribing and starting the CPAP treatment for the patient. That's going to be a higher level medical professional that does that, but it's absolutely your job to monitor. And because you are in here and you are learning to one day be managing care, you should know the indications and contraindications of CPAP. So make sure you review those and know why we use it, but also why we can't use it in certain patients. All right, guys, that's a quick overview on CPAP. Again, please continue to explore and learn more about it. See you in the next one.
Hi everyone, in this video we're going to be going over how to use the Resuscitator or radiant warmer. I'm going to teach you the most important things for you to know as a student. To start, I'm just going to go over the basic controls on this Resuscitator. So the first thing I want to start with is the power button. For this bed, it's located right here, this gray button. So you just press it and it turns the bed on. Take note that some of the Resuscitator beds are different, and sometimes the power button and the observation button or the lamp are up here, or sometimes they can be on the side of the bed. So we're just going to go over the basic controls on this screen, but again, they can look different depending on what Resuscitator you're using. So we use the power button. This button is the lamp. Sometimes it's called observation light, and you just press that to turn the light on the bed if you're doing a cannula or some sort of procedure that you need light for. These are the 3 different modes that we'll go over in more detail in just a minute. So you have pre-warm, manual, and baby mode. So anytime you want to change the mode of the bed, you have to first unlock the bed. So this is called keypad lock. So you'll press the lock button, change the mode of the bed, and then lock it again. So right now the bed is on manual mode. If I want to adjust how much heat the bed is putting out, I'll need to, again, press the lock button. These are the up and down controls for how much heat you're giving. So if I want to increase the amount of heat the bed is giving, I'll press the up button. And if I want to keep it there, I'll have to press the lock button again. So anytime you're changing the mode, or if you want to adjust the heat, you always have to unlock it, do what you want to do, change the heat, increase it, and then lock the bed again. So here is the skin temperature. So if you're using baby mode, then this is the temperature that the bed is reading directly off the baby's skin using this probe here. Set temperature, that's also for if you're using baby mode, and it will show you exactly the temperature that you're setting the bed to. So I'll show you. First, you unlock the bed, switch the mode to baby. I want my baby to be 36.5 degrees. That's a normal temperature. And then I'll lock the bed again. So I'm going to switch it back to manual. If your bed starts alarming at you, this is the alarm reset or silence button, so you can press that. Obviously, make sure that everything is okay with your baby and the bed is set correctly before you silence the alarm. There's an alarm on the bed for a reason, so just make sure everything's okay before you silence it. So to start, we'll just turn the bed on with this gray button right here. And depending on what resuscitator you're using, sometimes this part can look a little different, but all the beds work the same. So we're gonna go over the 3 modes that this bed uses. The first one is pre-warm. So if you can see here, there's 3 black boxes, and each of them is a different mode that the bed uses to warm the baby. So the first one we'll go over is pre-warm, and what that does is it provides heat to the bed before a delivery, maybe a C-section or vaginal delivery. So it provides heat to the bed and pre-warms the bed before a baby is set there. So if you want to change the mode, you click this unlock button here and then mode select. And now we'll go over manual mode. So manual mode is useful for short-term use for babies only. And the reason why is because whenever you set the bed with manual mode, say to 50%, and you lock it, the bed is going to give 50% no matter what. So it doesn't change, and it's really important to make sure you're monitoring the baby's temperatures very closely when they're on manual mode. So you set the heat to whatever you want. You can go up to 100%, 50%, 25%, and you just lock it there, and the bed is going to provide constant heat to the bed, and it doesn't change. So the third mode we'll talk about is called baby mode, and that is whenever you attach a probe to the baby's skin, and the bed will adjust how much heat it's giving to the baby depending on their temperature. So if the baby's temperature is low, it's reading that the baby's temperature is low based off the skin probe, the bed is going to increase the amount of heat it's giving to the baby. Versus if the baby's temperature is getting too high, the bed will decrease the amount of heat it's giving. So you'll first attach the probe to the baby. You'll have to tape it on their abdomen and make sure the baby is just wearing a diaper. They shouldn't have any other clothes on. So you put the probe on their abdomen, and then this area here is going to read the baby's temperature. And then this set temperature is whatever you set the bed to. So I'm gonna set the temperature to 36.5 and then lock it. So I'm telling the bed I want my baby to be 36.5 degrees, which is normal. And the bed is going to adjust how much heat it's giving to the baby in order to make them the temperature that you set, so 36.5. So there's 3 modes. One of them is pre-warm mode, which is helpful for before delivery occurs. Manual mode, which is good for short-term use only. You have to monitor the baby's temperature frequently because the bed is at a fixed amount of heat and it's not going to change. And the third mode is baby mode, which uses this probe to measure the baby's skin, and the bed will adjust how much heat it's giving to the baby. So the last very important point I want to make is to always check the temperature of your baby frequently using the thermometer. You never want to solely rely on the bed to monitor your baby's temperature. So the bed does not have a brain, you do, so make sure that you use it and check the temperature of your baby very frequently. So those are the most important things for you to know about how to use a resuscitator, and I hope this video is helpful. I'll see you in the next one.
So thank you. As I've said, I'm going to take you through the safety measures and how to use an incubator. Incubator, we have said, is a specialized machine that is used here at NBU. We use them for the babies who are preterm, very low birth weights, and also sick babies. It's used to give temperature, the standard temperatures. We have types, they are 2, open and closed. What I have here is a closed one. With my machines, it has different parts. It's covered with a transparent glass outside. Then it has the wheels that you can be able to move. You can be able to unlock and move the incubator to the desired area that you want. Then it has a start button where we can be able to start. You can be switched. If it's connected to the power, you can be able to switch. What we have settings, but you can be able to change according to the desired temperature that you need. It has the 2 readings, as you can be able to see from my side. Here it's the temperature inside the incubator, and this one is what you can be able, the temperature that you can be able to set. You can be able to lower or raise. So just press the start, then you can be able to either use the arrow facing upward, you can be able to raise the temperature. If you be able to press, you can be able to adjust from that 6 either to that 7, or if the temperatures inside you want to lower, you can just be able to adjust and lower the temperatures to the desired. That's also need to check. That's basically on the setting of our incubator. The other one we have talked about, it's providing the humidity to the baby who is inside. So our machines, it has some special area where we can be able to put some water. So the moment you come, you have to check this one. We have a trap that is filled with water. We need to clean it regularly. Sometimes that water becomes dirty, so we have to clean it regularly. Check your incubator. In case it's not working, you can call either the nurse who you're working with or from the maintenance office. In case you have come in, you have switched your machine, it's not working. It may be having some fault. If you are trying to warm the temperatures and temperatures are not rising, they're still low, know that there is something not working well with your machine. So you have to call the assistants or the qualified nurse who you have for quick assistance. Remember, although these are external temperatures that are recording, you have to check the baby's temperatures inside, because maybe sometimes machine could be having a fault that's giving a false reading. So you have to confirm the baby if what is here is what the baby temperatures are. So you have to confirm. That's why we also have thermometers. Use thermometers to check the actual baby temperatures. The other thing, it has a window. And also it also has fans. With mine, it has 4. It has this one, 2 fans here. And also I have the other one here. This is how it has something like handle. You can rotate it clockwise or anti-clockwise in case you want to open it. Sometimes temperature is high inside and you want to lower it. Once you have regulated here, you can open the fence and let some free air to circulate inside. The next one is about if you want to admit the baby inside the incubator. I've said we have the window, so we have to open the window. Here we have the bed or the couch that can be able to lie the baby. You also need to make sure before you bring your baby inside, it needs to be cleaned to prevent infection. So it prevents cross-handling or cross-infection for the baby because once they are protected. So not only you come and just reach the baby like once we are in a open incubator. Again, it also helps to protect, like here in Kitui we have mosquitoes and the other growing insects from reaching the babies. So once the baby is here, we are able to protect from those insects that can bite the baby. Once the baby is out, or once you have opened these windows and the baby is here, maybe we open this during feeding. You can open this one or when the baby is on phototherapy, we need to do turning and all that, change of the diaper. Ensure that once you are through with, this door is closed. You have to close this door for the safety of the baby, because some babies are very active. As you know, babies are very active and they can fall from this machine. Then we'll end up having an accident that could be able to prevent. So make sure the window is closed. So in summary, what we have said when the baby are inside, make sure the window is always closed for the safety of the baby. The other one, we have talked about the setting. Make sure the settings are correct. And also we have also said, apart from checking the setting, the temperature setting outside, which are correct, you also need to check and confirm with the thermometer that the baby's temperatures, because we have said machines have some fault. So it could be giving us wrong reading, yet the temperatures baby inside is different. So you have to compare the baby's temperature inside and what the machine is reading. So the last one is about the general cleaning of the incubator. Before you admit the baby to incubator, it has to be thoroughly cleaned. And once the baby leaves the incubator, it has to be thoroughly cleaned. And inside here, we have this one, the mattress with a couch. This one, you have to be covered with a different, we have a sheet. The sheet need to be cleaned to prevent cross-infection for the baby. So we don't want to have one baby who was here with a different case, then another baby comes in and gets that same condition. So ensure the hygiene of the incubator machine is highly maintained. Thank you for listening and watching. Okay, welcome again. I'm going to talk about the phototherapy. On phototherapy, we have incubator, baby who is in incubator, preterm with jaundice, neonatal jaundice, where we have the recommendation is that we do phototherapy. With me, I have offered the phototherapy machine, where we have, once you come in, it's connected to the power, so you have start button is from behind, from machine that I have. So I'll start with my machine, then it's going to give me a blue light. This light, once the baby is inside and we are set for phototherapy, before you put on light, ensure the baby has eye shields to prevent damage of the eyes. My machine, the phototherapy machines, has different setting and different colors. So standards here, if in case you want to give white color on the yellow one, you can give the light color, you can give blue, but here we use, during the phototherapy, we use the blue one. That's one is recommended for breakdown of bilirubins and neonatal jaundice, for the baby with neonatal jaundice. So it has different setting of different colors. The other one is about the intensity. The machine you can set high or low according to the recommendation of that the doctor has recommended on which intensity of lights we are supposed to give that baby. Once you come in, you have to confirm your machine is okay and it's working. It's the reading and setting are okay. In case there is any fault or in case it's not working, you have tried to put it on, then it's not switching it on, or you're not trying to change the lights and they are not working, please, you will need to consult or report to the nurse who is you're working with. Or you can as well call from the maintenance, come to check the machine in case there is any problem. So basically, that's what I think you have to know about the phototherapy. Thank you.
Yes, I'm back again. I will take you through jaundice. And jaundice is the yellow discoloration that baby usually have when they are born or 2 to 3 days after they are born. Like we start by doing examination on a baby. Like some we don't need even to do blood samples because we can see the yellow discoloration of the baby just from the sclera of the eyes, the extremities, the legs. You can examine and see this baby is becoming yellow. That is because of excessive breakdown of red blood cells that cause the accumulation of that waste in the liver. So we can do blood samples and see if the bilirubin levels are high. So we can start phototherapy on them immediately. Sometimes if the bilirubins are very high, we can do blood transfusion of the baby to replace the red blood cells that have been destroyed by the body. So this is the case now. This is our baby. So we're going to use this one. We have an integrated phototherapy system that we have a phototherapy machine and an incubator. So this one we can use in combination when we have a mature baby and premature baby. The case is we have a lot of mosquitoes around, so we put them here because we cannot put them on a net. So we first take vitals that we shall take is a temperature, because this one they are blue rays and they can raise the temperature of the baby. So we usually take temperatures before we put them there and sugars and ensure that everything is okay. So and then we use eye shields. Currently we use this one. This one is manually manually manned with the gauze and a strap in, so that we can shield the eyes of the baby. We usually apply it on the eyes of the baby like that. Well, they are inside the phototherapy. In our case, it's inside the incubator that is incorporated. So we tie just not too tight, but in a way that the baby cannot remove. And then we keep the baby on the central. So our baby's eyes are now shielded well. So we use the wraps like this one, the blanket and the bed sheet in this case. So and then after that we light. You see there's no light that is coming outside, it's just contained on the baby. So the other one is the intensive phototherapy that we do it in babies. So we take the samples, and when the bilirubins are very high, we use an intensive one. Like we have a top one, that one which lights blue, and then we have another one that is we put it on the back of the baby. That is in case that we have a very high bilirubin levels. This one we insert in the back of the baby, somewhere here. So we put it on the back of the baby like that. And then we shield the eyes, we light it, and then we light the other one, so that it could be intensive from top and the bottom. So in this case, as we are doing the phototherapy, it's good to examine your baby for dehydration, because these are the risks that can cause the baby to be dehydrated. You access if they are the urine output, how is the urine output, but the importance is we check the skin tag. You check the skin tag. You can pinch, and even you can just see just a rough skin that needs fluids. So if the baby is having low urine output, the mother reports that has not changed diaper like 3 times, that one is still almost becoming dehydrated baby. So we need to do fluid therapy on them. We can use a plain D10 on the newborns before 24 hours. After 24 hours, we can use the cocktail on the baby so that we don't have dehydration on these babies. Then remember to check sugars, because when they are here, you can forget easily. You can easily forget. So you just be keen when the babies are here, and then monitor the sheets so that they don't come out of the highs. Thank you.
Welcome back. In this video, I'm going to show you how to use the suction machine and the correct technique for when you do need to suction your baby. So something really important to keep in mind is that you should only suction if it's necessary. And by that, I mean if there's visible secretions that are blocking the baby's airway. So if you see some drool coming out of the baby's mouth, you don't need to suction them. You can just wipe that with some gauze or cotton. So only suction if it's medically necessary. So whenever you're using the suction, you always want to make sure that it turns on and is working. So you can hear it on. You have the tubing here. I'll place right here. And then you have the actual suction catheter that comes in different sizes. So you might need to suction at a delivery or in the NBU, but again, only if necessary. So you have your suction catheter. You'll just open it here. And this area is what connects to the suction tube here. So I'll connect it like that. Okay. And then you have your suction catheter. You always want to make sure that this stays clean, that you're not dropping it on the floor, because obviously this part is going to go into the baby's mouth. Okay. So whenever you turn on the suction, I'll turn it on. You can hear the air. This is a thumb control valve. So whenever your thumb is occluding the valve, the suction is on. So you can kind of hear it, maybe. So suction is on. Whenever your thumb is off, the suction is not going. So anytime you're inserting the tube, you always want to make sure your thumb is not occluding the valve. You don't want the suction going while you're inserting the tube down, because that can cause a lot of trauma. So you insert the tube down, then you occlude and you pull out. And whenever you're suctioning, you only want to suction for 10 seconds at a time, because this tube is blocking the baby's airway. So 10 seconds max, you'll pull the tube out and give the baby 30 seconds in between suctioning. So again, your suction is here, you turn it on, you insert the tube down, leaving this thumb valve open, and then whenever you're going to pull out, you occlude the valve, pull the tube out for 10 seconds max, and then you'll give the baby a break for 30 seconds. Okay, so that's the basic way to use the suction machine. Again, only suction if it's medically necessary, and I hope that this video is helpful.
All right, congrats on finishing your orientation video. Now I just want to go over some key takeaways for you to remember. The first one is that we're aiming to correct our deficiencies and make the NBU as safe and effective of a unit as possible. The second one is to always ask for help. Never be afraid to ask for help, especially if you are in an emergency situation or are unsure of anything. The third one is that it's really important to remember that the NBU is a critical care unit and should not be treated like a nursery. Lastly, and most important, our neonates do not have a voice and they cannot advocate for themselves, so you as the nurse are their advocate.
Absolutely. And some things we want you to remember are, one, make sure that you always show up on your first day and every day to your rotations with the necessary foundational knowledge to make yourself as effective as possible in caring for your patients. Two, when you're in the NBU and in maternity and throughout your career as a nurse, always follow the proper protocols and respect the rules that you operate within. Third, make sure that you effectively monitor your patients and very diligently keep your eyes on them and be sure to be on the lookout for any red flags or complications. If you detect any red flags or complications, make sure that you immediately contact the nurse in charge and get help. Fourth, while you're in your rotation, make sure that you are utilizing the equipment effectively and within the proper limits of the settings that that piece of equipment should be used. And then finally, always ask questions. Learning is a lifelong process, and it's going to make you a better nurse, and it's going to increase your ability to care for your patients.
So always remember your personal limits of competencies and never perform unsupervised work that is beyond your training. Always carry the content from the orientation during your daily routines. Always accept feedback from the nurses and also from your clinical instructors and work on improvement so that you can always have better patient care. And take responsibility for personal learning and also taking care of the patient and ensuring patient safety during your rotation. Take initiative to learn, and if you are unsure of anything, always ask.
All right, guys, please know that we are very proud of you, proud of your desire to serve your patients, and we are so excited to see you grow into incredible nurses.
All right, so thanks for watching, and go
be
great.
That was fire.